Uh, Assalamu alaikum. Am I audible to you? Can you hear me?
Yes, sir.
Yes. Okay. So actually, the topic which I just wanted to discuss today, that if what sort of respiratory challenges you will have when you have a patient with some respiratory disease. Okay, what would be the challenges? So if I just Azhar, if you just try to think that if you just come to know that you have a patient with some respiratory problem, so what can be those respiratory symptoms which the patient can have?
Sir, patient may have cough, patient may have a fever, patient may have a dry or productive,
Okay,
patient may have a shortness of breath,
okay,
and then afterwards we will see the clinical signs like he may or she may have a wheeze, she may have a patient may have a crates.
okay. What else? Cyanosis,
Increase respiratory rate.
increase respiratory rate, tachypnea. Okay, okay. What else? Respiratory distress. What about tachycardia or any other coexisting thing? Okay, which may be associated with it. Okay. What about clubbing? Okay. What else? Anything else? Just think.
Kyphosis, fine deformity of structural
Kyphosis. Okay. You mean to say chest
Edema,
wall
peripheral
deformity?
edema.
Chest wall deformities.
Yes, sir.
Okay. What did you say? Edema?
Yes, sir, edema.
Edema where?
Peripheral edema, sir.
Peripheral edema. Okay. What about JVP? Is raised JVP directly or indirectly related to lungs as well?
This is indirectly related in case of right heart failure.
Or also, but right heart failure may be associated with pulmonary hypertension. Okay, or usually it is associated. Okay. So what else? When we say cough, you only say dry and productive. Can there be hemoptysis? Okay. Just think.
Yes.
Anything else? When you talk about this, these are signs of lower respiratory tract. Okay. So what about upper respiratory tract? So there may be this stridor. Okay. What else? These signs of respiratory distress. Think about it. What are these signs of respiratory distress? Please, like nasal flaring. Okay. Use of sternal.
Accessory muscles.
Can you please mute yourself, please? Okay. So sternal, like sternal recession. Okay. And just think about a patient with the COPD. So this they fix their scapula and they do this pursing of lips. Okay. So it's also sort of distress. So like you may have some other signs and symptoms as well, but just think about it. And then if you find these things, what will be your next step? Like you will be doing some chest X-ray, you will be doing ABGs, you might do ECG, okay, you might do pulmonary function tests, okay. So your main aim is to see whether this is a mechanical problem, whether this is a problem related to some parenchyma, okay, whether there is just related to gas exchange, similarly, okay, and if it is related to cardiopulmonary coupling, you can say the correlation between cardiac system and pulmonary system, okay. So how can you assess the mechanically? What test you can do, or what is the most important test? Spirometry.
Chest X-ray.
Spirometry. Spirometry, okay. Or this PEFR, peak expiratory. You will test the mechanical means that volume, chest X-ray, yes, indirectly, but if we just objectively see how is the mechanical function of the lungs, okay. So mechanical function is this buccal hand movement and the which are resulting in this compliance of the lungs, compliance of the wall, that will be affected either in obstructive or restrictive lung disease, okay. So the result is you can find in the form of this lung volume and capacities, okay, this tidal volume and FRC and FE1, okay, FVC, TLC, okay. So like these are the things, vital capacity as written here, okay. So this will be giving you an idea whether the mechanical function of the lungs are okay or not. And if you want to see whether gaseous exchange is good or not, so what will you do? You will do ABGs.
ABGs.
Okay, and what else? Diffusion capacity, not everyone is doing it, but there is another test which can also tell you about the gaseous exchange and the cardiopulmonary. It is CPAX testing, this cardiopulmonary exercise testing. Okay, so in ABGs you might have low PO2 and high PCO2. Okay, any change in pH. So that's how you will be approaching towards, like, then you will label it as respiratory failure. Okay, so that's how you okay. So you said about chest X-ray. So what finding you can get in chest X-ray in problems with lungs? What can be the different things?
So this depends on the disease process. Actually, we may get a hyperinflated chest. We may get opacities. We may
Atelectasis. Okay.
Any rib fracture.
Okay, rib fracture
Um,
also. But rib fracture are not directly related to respiratory system.
Pneumothorax.
Increase
But it will affect.
Increase bronchovascular markings. Okay, pleural effusion. Okay, what else? Pneumonia. Findings of pneumonia. Okay, so these thing will be, now you will have some symptoms, you will have some signs, you are doing some investigations. So you might have some changes related to respiratory system, as for example this P pulmonale, okay, or this right axis deviation. Okay, so that's how you will be combining your findings. Okay, and then you will label it as some like any restrictive disease, okay, or obstructive disease or restrictive disease or some infectious process. Okay. There are some other tests which you will be doing in addition to this sputum examination, sputum culture, this Graham staining and this and that. And you might need some diagnostic, like for example, if you suspect any TB or something like that. So there are quantiferon antibodies test. Okay, and this what you do for TB, whether that this skin Monto's test. Okay, or sputum this for AFB. Okay.
Tested fast training.
Yes, AFB. Okay. So what also you can do bronchoscopy. Okay, bronchoscopy with either this bronchoalveolar lavage or protected specimen brushing. Okay, so this is how you will be evaluating. Of course, echo will be one of the portion, but that's how. Yes. Anyone wants to speak out something? Okay, so that's how you will be evaluating. Okay, you will be evaluating in that way. So at the end of the day, you will say that this patient has some pulmonary risk factors. Okay, so of course there will be one of the component which is anesthetic component, and one of the factor will be surgical factor, and one will be the patient factors. Okay, so we are actually up till now you are focusing on the patient factors, that if patient has some COPD or patient has what about low albumin, is it a risk factor?
No. जी ठीक है.
Low albumin is a pulmonary risk factor. Okay, because if patients have low albumin, it might lead to, we have missed a very important pulmonary risk factor up till now, which is usually at the top when we are taking
Smoking.
smoking. Okay, so smoking is manas, and it is related to not only the some of the components which it has, like carbon monoxide and tar. Okay, but it also has effect on the mucus production and mucus clearing. Okay, so in this way, and this patient will be suspected any risk factor in addition to, or like airway reflexes like bronchospasm. Okay, like pneumothorax. Okay, hypoxia, hypercarbia. Okay, laryngospasm also, but mainly related to upper airway, lower airway. So these patients will be who are undergoing surgery, and also respiratory insufficiency. Okay, because all anesthetic drugs will be creating problem, and then respiratory depression. And of course, if we have some surgical risk factors as well, like upper abdominal or thoracic surgery. Okay, so it will add to the problem, like the patient will not be able to breathe out, and there will be atelectasis. Okay, and it will further lead to infections, hypoxia. Okay, one more thing will be related to, like for example, if patient is already hypoxic and the patient was dependent on hypoxia. So like for example, if you are giving too much oxygen, this itself will cause respiratory depression. Okay. Similarly, the patient had hypercarbia. Okay. And you wash out CO2, patient will still have respiratory depression. Similarly, the lungs were fragile emphysematous, and you give increased positive this peak inspiratory pressure, and it can lead to pneumothorax. Okay. Similarly, you manipulate the lungs, manipulate the airway in light plane, and this patient is going into bronchospasm. Okay, which may be even very severe, and it can create problem to you. Like if you have a patient who needs increased expiratory time, okay, for like in any obstructive disease, there is problem in the expiration. So you might need to adjust accordingly, increase expiratory time. Okay. And what about PEEP? PEEP usually is helpful, but it can cause itself problem as well with relation to like pneumothorax. Like if you are giving too much PEEP, it itself can create problems. Okay. So like that's how. And then if, for example,
Excuse me,
yes.
sir. Can I ask a question?
Yes, other.
So in case of bronchospasm, can PEEP create air trapping?
Yes.
Because there will be a difficulty for the air to come out, isn't it?
Yes, actually, that's why the use of PEEP is a is a tricky thing. Because there are problems related to air trapping because of if the expiratory time is not adequately maintained. Okay, but at the same time, this patient also can have atelectasis. So you have to optimize the PEEP in a way that you are able to not only ventilate properly, oxygenation is not hampered, and at the same time, this problems related to air trapping or development of auto PEEP you are avoiding. Okay, so because the treatment of auto PEEP is PEEP intrinsic, this intrinsic PEEP is that you give extrinsic PEEP accordingly. Okay. Similarly, you will avoid histamine releasing drugs. You will avoid medications which irritate the airway, like for example, desflurane or isoflurane. Okay. Similarly, you will avoid thiopentone. Okay. Though ketamine is documented as relatively better, but it increases secretions, so itself can create problem. Okay. So you will find some of the people will have allergy to NSAIDs, so you will avoid NSAIDs, or you should be using it with caution. Okay. So like use of regional anesthesia will be a caution, with caution. Okay. Because regional anesthesia, both if you are giving upper limb blocks or central neuraxial block, both of them can create problem. We have discussed a number of times that if phrenic nerve, you are blocking it in this as in brachial plexus block, interstitial linea or supraclavicular, it can create problem. It will, the patient who is dependent on abdominal this phrenic nerve, once it will have problem. Okay, he will have respiratory insufficiency. Similarly, if you give central neuraxial block in these patients, so apparently it looks fine, but the patients who are dependent on the abdominal muscles and extra thoracic muscles, when they are blocked by a high spinal, like high level spinal, like the mid thoracic, so it can create problem to them. The patient might, if for example, if you are doing in local anesthetic, okay, the patient is not able to lie flat on the bed, it can create a problem. Okay. Similarly, these patients may have commit an OSA or coexisting other diseases, so it will create further problem. Okay. So these are the challenge, because my aim for this discussion was just to give you an idea that you think you have a, because generally these are total practical things. How you evaluate a patient for respiratory related to respiratory system and how you anticipate. Okay, so you will be using pressure control ventilation. You will be using, according to the situation, you will optimize your way of anesthesia. People say that regional anesthesia will be safer. Yes, because you are avoiding a number of complications, but still this patient can have problem even in regional anesthesia, whether central axial block or whether upper limb blocks. Okay, so actually nothing is safe. So you might need HDU for monitoring. You might need to have a strict meticulous monitoring of airway pressures. You have to optimize the ventilation accordingly. Okay, you might need to do serial ABGs. You have to do a baseline ABGs, so that in that patient you will not be changing it. You will try to have that thing. Similarly, COPD patient, you will need some optimization if you have the time. Okay, according to the surgery and according to the time you have. So you can have chest physio, you can have incentive spirometry, you can have bronchodilator, you can have steroids, you can have mucolator, this N-acetylcysteine. You may drain pleural effusion. You might treat heart failure. Okay, so all these things with antibiotic, as I told you, steroid, I told you, just physio and incentive spirometry, all of these will improve the respiratory parameters. Okay, so if similarly some other extra things like the patient undergoing some thoracic surgery for CA or empyema, things like that. So you will be evaluating the patient is in thoracic surgery specifically. Your aim will be to see whether the patient will be able to tolerate the pneumonectomy or lobectomy or segmental resection, whatever they are planning, because you will have a criteria for that. You will be doing predicted post-operative FE1. You will be doing the baseline ABGs. You will be doing this spirometric evaluation. So on the basis of those things, you will be able to see whether the patient will be able to tolerate. And also you will do this cardiopulmonary exercise testing, in which both the system of cardiovascular system and pulmonary systems are evaluated. Gas exchange, they are taking how much oxygen patient is consuming. Okay, so they are directly they are measuring the maximum oxygen being utilized. They are measuring the anaerobic threshold, how much PCO2, how much PO2. Like, it's a combined test, and there are some other tests as well, but the basic function is to see whether patient is able to tolerate the stress or not. Okay, so that will be operability and resectability, and the patient is able to tolerate it or not. So, okay. So smoking, you will be cessate. And similarly, if you have a patient, this carcinoma patient, so it will have all the concerns related to cancer as well with you. Okay. And yes, one thing I forgot to tell is occupational protection. So if you have a patient who has some respiratory problem, so you have to do contact precaution. You will be using N95 mask. You will be using the equipment accordingly. Okay, so you will be informing the whole staff. So whether airborne infection or droplet infection. So in this COVID era, this topic is a very hot topic. So basic principle of your evaluation is, now from where we started, we just see what are the common symptoms as Azhar you started, shortness of breath, dyspnea, cough, sputum, fever, and then you will be evaluating the severity of the disease, clubbing, cyanosis, all this you will be having chest expansion, this vocal fragmentus, vocal resonance. You are auscultating any added sound, any signs of respiratory obstruction, any flaring. Then you will be chalking out. Then you will be doing some investigation, and then you will say this patient has baseline this that much pulmonary function, and you are anticipating the problems. So actually, this is what I wanted to it's a sort of a different topic, but practically it's very important. And for all people who are preparing for any long case, or even this topic is like in the way I have discussed, this is very important for the juniors, because all of you are tackling the patient daily. And if you make your approach like in the last discussion, I discussed in the similar way the cardiovascular system. Okay, so Sumaira, I think you understand. So you just correlate. I think it is better if you listen to the last discussion as well. So that is what your long case is. Even long case, in the long case, any patient you are dealing, you have to evaluate the patient in the similar fashion. Okay.
Okay, sir.
So any questions before we finish? Because rest of the things, Sumaira, in the same case, they will be asking you about COPD. So these are typical questions. What is COPD? What is emphysema? What is bronchitis? How will you evaluate? They will be asking you this what do you say, match test. In our exams, they are asking even things like that. In the examination, you will be doing the inspection, palpation, percussion, auscultation. You will have all the parameters, which I actually, a number of things I discussed with you. So, okay. So yes, Aves, I hope your mic will be working better, because all the time we are not
Okay.
able. Yes.
Is it okay now, sir?
Yes.
Sir, I want to ask, you have mentioned some exercise test for interpreting the lung function of a patient. So kindly explain it a
Which
bit,
test?
how they
Which?
are, the results are.
I'm sorry. Which test you said?
Exercise related to lung function. Sir, you have mentioned it.
Cardiopulmonary exercise testing. Okay, this is just like, you can say, combination
Okay,
of
sir.
exercise tolerance test, and they are putting a mouthpiece and they are measuring, they are giving the information about the oxygen consumption, CO2 production. Okay, they are having the ECG leads as well, and they are asking the patient to move on a machine. It is just like an exercise tolerance test, but it is combined with
Okay,
the
sir.
respiratory parameters. Okay.
That VO2 max, sir, is it
Yeah,
the
VO2
same
max.
thing? VO2 max.
VO2 max and
Okay, sir.
anaerobic
Okay, sir.
threshold. Okay, there is an article about it. You can see in the respiratory, in the cardiovascular system, you will find it. Okay, cardiopulmonary exercise testing.
Sir, in anaerobic threshold, they also take, I think, arterial samples for 15 minutes continuously.
Yes, yes.
Thank you, sir.
So okay, everybody. Thanks a lot for your presence. So inshallah, tomorrow we will discuss other system, most probably renal and liver. Okay, in the similar fashion. So that actually it will be helping the people who are preparing for the long case as well, and for the juniors as well. Okay, so inshallah, so we'll meet tomorrow, inshallah, same time. Bye bye.